So who's presenting today?
Sir, Dr. Sneha and me are presenting. Dr. Sneha
Okay.
is from JR1 batch. I'm from JR2 batch.
Okay. Any of the gynae consultant is joining? Do you know?
Uh, no, sir, I don't know.
Okay. So who's presenting today?
Uh, Sir, Dr. Sneha and me are presenting. Dr. Sneha
Okay.
is from JR1 batch. I'm from JR2 batch.
Okay. Any of the I think we can start the meeting now, please.
Good morning, sir. Good morning, everyone. Myself, Dr. Sneha, and JR1. We are going to present. Am I audible?
Yes, you are audible, Sneha.
Yes,
So
sir.
Sneha, have you done a gynae posting yet or not?
No, no, sir, not yet.
Okay. I think we should also see that. So for you, it is all theoretical. You haven't had gynae posting.
Yes, sir.
Saurabh, you had gynae posting?
So yes, it was my like 1.5 years back.
Okay, one of your first postings.
Yes, sir.
Okay. Okay, carry on.
So today we are going to present toxicities of RT and chemotherapeutic management of locally advanced cervical cancer. Today's ward round is the continuation of the previous ward round. We'll begin with the case summary of last ward round. 58 years old postmenopausal lady presented with complaint of non-foul smelling white discharge per vaginum since 1.5 months and pain in lower abdomen since 1.5 months. There was no comorbidities. Patient was diagnosed as CA cervix 2B, C, 3C, 2R. Patient was planned for extended field radiotherapy with concurrent chemotherapy followed by brachytherapy. Patient received EBRT, a dose of 45 gray into 25 fractions over 5 weeks, along with simultaneous integrated boost of 55 gray by 20 into 25 fractions to gross nodes from 10th May 24 to 19th June 24, along with 5 cycles of concurrent chemotherapy with cisplatin 40 mg per meter square. The last date for concurrent chemo was 14th June 2024. Patient also received brachytherapy. First ICA was done on 21st June 24. Geneva 6 centimeter, 30 degree CT, 1.3 centimeter ovioids were used, and patient received 7 gray into single fraction. The second ICA was done on 25th June 24. Geneva 6 centimeter CT, 30 degrees, ovioids of 1.3 centimeter was used, and patient received 7 gray into 3 fractions. So we'll move on to the radiotherapy toxicities. The therapeutic ratio or index is the percentage of tumor control that can be achieved for a given level of normal tissue damage. The dose response relationship is sigmoid in shape for both the tumors and normal tissue. In this hypothetical example, about 30% tumor control can be achieved for a 5% incidence of normal tissue damage. So,
Whenever you say, was that for early effects or late effects, what you were showing?
so this is the early effect.
Early effects. How do you know that? You just said that very confidently.
So I have read some.
You have read somewhere. Okay. I think many times when you read Eric J. Hall or radiobiology book, they are not mentioning it whether it is for acute effects or late effects. But you should, because these two, why do you distinguish early effects and late effects? On normal tissue, I'm talking about. Why do we need to distinguish between early effects and late effects?
So
How does early reaction or acute toxicity, how does it, how is it important? And
So,
why is late toxicity important?
So the management for both.
Maybe your JR2 can answer.
So the management of both will be different. So sir, early effect will occur early during the treatment, and we have to give immediate.
Is it only during the treatment?
Sir, within 3 months of treatment, the early effects can be seen.
What is the impact of acute toxicity on acute radiation toxicity?
Sir, the treatment can stop if it is more
It can
severe.
be interrupted or
Yes.
delayed. Okay.
Yes, sir. Yes, sir. So,
It may be interrupted or delayed. And why? What is the relevance of that in customer service?
sir, accelerated repopulation can occur if the OTT is increased. So,
When
after
you said a
20
full form, OTT stands for
overall treatment time. So, if it after if it goes beyond
okay. So it may cause interruption of treatment.
yes,
It may increase overall treatment time, which translates into
uh,
overall prolongation of
yes,
overall treatment time.
sir. The tumor control uh, gets worse if we increase the overall treatment time and chances of
So,
recurrence increase.
so acute toxicity is also very important. It may affect your chances of cure. Okay, the
Yes, sir.
patient won't live long enough to develop late toxicity. So you should, and acute toxicity and late toxicity, they're very important. And for late toxicity, you've already completed your treatment. So how does that affect? What does it affect?
Sir, the quality of life of patient.
Quality of life of
Yes,
patients. Okay.
yes, sir.
So both are very important. So when we are giving radiation part of the treatment, you have uh, you have to keep activity which is manageable, which does not affect the quality of life so severely that you have to interfere or interrupt the treatment. Okay, either you reduce the total dose or this thing. And the approaches, and then of course, late effect should be such they should be very low. Ideally, it should be 0%, but severe, irreversible late effects which impact the quality of life, they should be very low. Single digit, within single digit only, it should be less than just 1, 2, and not more than that. If it is
Yes.
more than that, you have to go back and think whether it is due to technique, whether it is your total dose, fraction, or the volume. So you have to work on that. Okay, carry on.
Uh, Early and late toxicity, late effects of radiation therapy. Radiation effects are acute and late. Different patterns of response to fractionation. The late effects are more sensitive to change in fractionation than early effects.
So, sorry, before that, just summarize. And you all had not informed any of the gynae consultant. You had not sent the link to any one of them. I mean, the same thing has to be told every time about.
No, sir, we received email, but not the link, or maybe I missed it. Email
No, I
had
don't.
come. Yeah.
No, ma'am, none of us had the link. We just got the presentation.
Gynae 2, 3 of all of them. So I'm sorry about that. So please summarize the case. Please, what was your case? Can you please summarize the case?
Yes, sir. 50 years old postmenopausal lady.
No, just okay. So it is say cervix stage 2B, C. So what is it? And extended field radiotherapy. So what is C? What is R? If you remember last time we discussed 2B, C and 3C2R. What is it?
Sir, 2B-C is the parametrial involvement in case of
No, you had described this case. Today we're just showing the summary, but because we look at the toxicity, we should know.
yes, sir. Sir, 2B-C according to the FIGO 2000.
Were you there in the last water round or not?
Yes, I was there. Hello.
Sometimes showing a diagram. I know today we're talking about toxicity, but we are talking about a case. So you should know. And when you say extended field, what is extended in that? Where is it extended? To inguinal nodes, to medial nodes, to supra? Where is it the extension? What do you mean by extended?
So extension to the pelvic wall.
No, sir. The paraortic nodes are the borders are from the common iliac bifurcation are taken in extended field radiotherapy.
What? Who presented this case last time? Are you there in the?
So Shajan presented last.
Yes, sir. Yes, sir. I'm here. Sir, I presented it last time.
Bolo. So
Sir,
what was the case? Tell us.
sir, CA cervix 2, diagnosed was CA cervix 2B as per clinical examination because the lesion was involving the parametrium and R
Yeah.
is for radiological and radiologically it is 3C2 because 3C2 is involvement of the paraaortic lymph nodes. So because of the involvement of the paraaortic lymph nodes, we have to extend our field to the paraaortic region. So extended field means involvement of the paraaortic region also. When normally you take it from the common iliac bifurcation to include the pelvic lymph nodes, you are extending the field to paraaortic region.
Okay, good. So, if they had attended the previous, they must have attended, but they did not get the gist of it because when we'll talk about the toxicity, volume is important. Okay.
Yes.
Okay. Carry on. Next slide, you show how was the treatment. No. Before the slide before how you so EFRT.
Received
No.
EF.
Next slide where you're describing the treatment. So, Shejin, you please tell us what was the treatment. I think they're. So one of them hasn't had a posting, gynae posting. Other one had the first posting 1.5 years ago. So, bolo. Shejin,
हाँ sir. So
how
patient
was he treated?
so the treatment plan was concurrent chemoradiation therapy. The EBRT will be extended field radiation therapy followed by brachytherapy. The extended field radiation therapy was to a dose of 45 gray in 25 fractions. This is delivered over 5 weeks along with integrated boost of 55 gray in 25 fractions to the gross nodes, which she received over a period of from May to June 2024, and she received 5 cycles of concurrent chemotherapy at the rate of 40 mg per meter square along with the EBRT. Then she received 2 intracavitary applications of brachytherapy for a total dose of 7 gray into 4 fractions.
So now tell me what was the dose per fraction of extended field radiotherapy and why was it so? Dose per fraction of EFRT, extended field RT.
Dose per fraction is
You have to calculate. You know that.
2 point.
What is the dose per fraction? Do we keep it 2 gray, 2.25, 1.8, 1.5?
So 1.8, the dose per fraction.
1.8. So why it was kept 1.8? Why not 2 gray? You could have just finished it,
Yes, sir. So we are irradiating a large field which pose minimal dose to a lot number of the organs at risk, uh, including the duodenum, the bowel loops,
I think that's all right. But you should be always mindful what is the dose per fraction also. Okay. So when depending on your volume.
Yes,
And
sir.
the first thing we said, how acute toxicity could compromise your treatment. If the patient has severe vomiting or bone marrow suppression or other things, then it'll. So which toxicity will reduce acute toxicity by reducing dose per fraction? Bowel toxicity or bone marrow toxicity? Tell me between the one, if you have to choose, or it will be equally good or bad for both. So I'm giving you 2 organs. Okay, normal tissue toxicity on bowel by reducing the dose from 2 grade to 1.8. Which organ toxicity, acute toxicity manifests less? Bowel or bone marrow? Both.
Well, toxicity will
Which?
bowel toxicity, sir.
And bone marrow toxicity influenced or not by reducing from 2 grade to 1.8?
Not sure, sir.
Not sure. Who would like to answer, any of the residents? So you agree with him? He said only the bowel toxicity and not the marrow toxicity. Anyone disagrees? Or I think this is for food for you all to food for thought. Think and answer that later on. Okay, in the comment section of the YouTube. Carry on. CT stands for first year.
CT.
CT is, go back.
So
CT what? Chemotherapy, CT scan. Right. तुम्हारी तो गायनी पोस्टिंग भी नहीं हुई है. So what is CT? Is chemotherapy, CT scan or what? See, you whenever you are presenting something, you may not have seen that case, but anything which is written on the slide, you should understand. You are present. I think it is really very bad for anyone, especially for student, if they are presenting a slide and do not understand what is the meaning of the word that is written on that slide. JR2 who's presenting, बताओ CT क्या है?
Sir, it is the central tandem, sir.
ठीक है, thank you. चलो, carry on.
the early and late effects of
Yeah, we discussed this.
if intensive
क्या है
fractionation
ये? You were saying acute toxicity. Now you want to change. What is this curve on acute toxicity or late toxicity? Go back. See, radiobiology is a nice thing also, but very easy, also very difficult. When you are reading it, you can read it like a flow. It looks like as if you have understood everything. But after some time, when you try to recall or someone asks you a question, it can confuse you also. Okay. So at the time of reading, like physics, when you read it slowly because it is difficult to understand, take time to read. And whereas radiobiology, we just read it in a flow. So radiobiology also, you have to read it slowly and understand every graph, every curve in Eric J. Hall is very important. So and because we don't write the legend of the figure, we just put a figure. Sometimes in the legend it is written, sometimes in the text it is written. So you have to know what it is. Is it normal tissue damage, acute or late? Carry on. You said it is acute toxicity. You go and read yourself and tell me.
Yes. Moving forward, if intensive fractionation protocols deplete stem cell population below levels needed for tissue restoration, and early reaction in a rapidly proliferating tissue persists as chronic injury. This is termed as consequential late effect.
Sorry, can you please explain what it means for gynec extensive fractionation protocols?
She said intensive.
No, I just wanted to, sir, understand what it means for gynec radiotherapy. What is intensive fractionation protocols? Because normally intensive fractionation for EBRT are generally for head and neck. So for gynec, what does this mean?
So Supriya, who's presenting, she's JR1. She never had a gynae posting. You should ask the JR2 who had a gynae posting, but in the very beginning.
We'll keep it for later. No problem, sir.
Okay. Carry on.
Radiation toxicity, any unwanted, unavoidable effect in normal tissue as a result of therapeutic radiation to the tumor is considered to be toxicity. Can be broadly termed as acute toxicity and late toxicity based on the time of appearance of symptoms. Acute toxicity is present as early as during course of radiotherapy to a maximum of 90 days. That is 3 months. Late toxicity is usually present after 3 months, after 3 to 6 months of completion of radiotherapy. Radiation dermatitis. Skin cells are radiosensitive. They are rapidly producing stem cells. The basal keratinocytes, hair follicle stem cells, and melanocytes are highly radiosensitive to ionizing radiation. Acute injury occurs within hours to weeks after radiation exposure, whereas late injury presents months to years after exposure. Acute skin reactions, they reflect inflammatory response to ionizing radiation. There is a dose-dependent loss of cells from the epidermis, dermis, and microvascular endothelium. Fields treated with a conventional 2-gray daily fractionation do not cause any changes in the basal cell density until total doses of 20 to 25 gray are delivered. Factors affecting the incidence and severity of radiation dermatitis. The patient-related factors and treatment-related factors. Patient-related factors, we have age, that is old age, connective tissue disorders, ataxia, telangiectasia, Fanconi's anemia, smoking, diabetes, obesity, microcirculatory impairment, infection, poor nutritional status, which occurs in anemia, and immunocompromised status. Whereas the treatment-related factors are high total radiation dose, high dose per fraction, that is 2.5 gray, kilovoltage radiation, use of bolus, large irradiated volume, concurrent chemotherapy, and overlapping fields. Radiation dermatitis, pathophysiology. Radiation to the skin results in direct cellular injury and inflammatory cell influx. Initial cellular injury results from short-lived free radical production and irreversible double-stranded breaks in nuclear and mitochondrial DNA. Repetitive cellular damage caused from each fraction of treatment does not allow time for cells to repair the DNA damage. The RT dermatitis grading. Grade 1 is faint erythema or dry desquamation. Grade 2 is moderate to brisk erythema, patchy moist desquamation, mostly confined to skin folds and creases. There will be moderate edema. Grade 3, moist desquamation in areas other than skin folds and creases.
Sorry, can I interrupt? What CTCA version are we currently following?
Sorry, ma'am, your voice is breaking.
CTCA, you've written CTCA version 4.3. Which version are we currently following? Which is the latest version?
5.6.
Yeah, so you should mention the version 5.0
Yes, ma'am.
for all toxicities.
Yes, ma'am. Grade 4, dermatitis is skin necrosis or ulceration of full thickness dermis, spontaneous bleeding from involved site. Timelines, acute skin effect, that is early transient erythema, which occurs at the dose of 2 gray and onset is within hours of the delivery. Faint erythema and epilation, it occurs at 6 to 10 gray, onset is 7 to 10 days. Definite erythema, hyperpigmentation, which occurs at 12 to 20 gray and onset is 2 to 3 weeks. Dry desquamation.
Any of the third-year residents here, how do you know that there is erythema? Do you see it? Janelle or anyone? Any of the more senior students? How do you know? How do you say there is erythema? Do you see it? Always? You only tell now if you know. Smelika, faint erythema. Faint erythema means what? It's a Latin word, okay? Erythema means what? To translate it into English, erythema means what?
Reddening of the skin.
Redness of the skin. So do you always see that in Indian skin?
So in pigmented skin, it is difficult to see versus the.
So then how do you know there is erythema? That means you directly. So how do you know there is erythema? So when you say erythema, there's one feature. When you give a name, they have defined by one feature, which is the redness. Okay. So other than redness, what else happen in a skin which has developed erythema? edema because of radiation, as an acute effect of radiation. What else? What are the other features which you can note it? And based on that, you would see that. Someone has a really dark skin, okay, you will not see redness.
So raised temperature in the treatment.
Is temperature, okay? So you put your hand, on that side, irradiated skin, and outside, you will immediately note the change in the temperature. Okay, carry on.
Right.
Okay, so few of them have answered. Arunima and Shreya. Good, very good. Carry on.
Dry desquamation occurs at the dose of 20 to 25 gray, and the onset is 3 to 4 weeks. Moist desquamation occurs after the delivery of 30 to 40 grays, and onset is generally 4 weeks. Ulceration is more than 40, occurs after 40 gray, and onset is 6 weeks. Radiation-induced fibrosis mediated
So when you have previous slide, that is confusing. That means every patient who will have more than 40 gray will have a ulceration. Every patient would have moist desquamation at 30 to 40 gray. That dose, what you are writing. And in mega voltage, how often do you see moist desquamation? How often do you see ulceration? I think, okay, we'll move on. But you all should, when it's on the slide, you should know yourself. Every
So just a minute. So
more
can
than
I
40 gray.
so can I interrupt for a minute?
Sure.
Can you go back to the factors affecting causing radiation dermatitis? The factors. Yeah. So okay. So can you explain how you've written kilovoltage radiation? Okay, how the energy of irradiation would cause different grades of radiation dermatitis, or would increase the chance or decrease the chance of radiation dermatitis, and plus another factor that you've missed here. Anything related to the field arrangements or usage of number of fields, 2 fields, 4 fields. That is very important for if you're treating the pelvis in a patient of CS cervix. Any of the senior GIs.
Ma'am, in mega voltage radiation,
clinical practice, which patient is at the highest risk of developing moist desquamation and where? If that patient, by the time this lady would receive 40 gray or 50 gray, there will be moist desquamation. When you see the setup, you will know that. If suppose it's a direct anterior field or parallel opposed field, if you see the setup, this patient will develop moist desquamation here. And what is that factor? That is not written in this. Bolo, anyone? Put your comment. This should be,
sir, in mega voltage radiation, depth of penetration is greater than that with kilovoltage radiation. So there is skin sparing effect. And
skin sparing effect. When we
yes.
are treating with mega voltage radiation, in which patient at the start of RT itself, you will tell this patient will develop moist desquamation after 40 gray, and this is a place where he or she will develop moist desquamation. What is that factor?
So in skin folds, usually we get
Skin fold, so self-bolus effect, which is not
yes.
on this slide. Okay. So
Yes.
there, and because whatever she said, there the skin gets full dose. Okay, carry on. Let's come to the main parts of CS cervix toxicity. We are stuck with skin. Okay. So radiation induced. Is it acute or late effect?
So this is late effect.
Late effect. Okay.
So, radiation-induced fibrosis is mediated by inflammation, which begins immediately after RT and continues for months to years. Inflammatory mediators are tumor necrosis factor alpha, interleukin-6 and interleukin-1, TGF-beta, PDGF, and connective tissue growth factor. Fibroblasts are the key cells in the development of late radiation-induced fibrotic changes. The concomitant RT-induced endothelium damage results in improper vascularization of irradiated skin and restricts blood perfusion, resulting in telangiectasia. We have a paper here. Clinical practice guidelines for prevention and treatment of acute and late radiation reactions. They recommended strongly in favor of prophylactic washing with water, with or without mild soap or shampoo use. Strong recommendation for use of active perspirants was given. and prophylactic use of topical steroids. However, there was weak recommendation in favor of silver sulfadiazine cream antibacterial for antibacterial effect, and strongly recommended against aloe vera and trolamine. NSAID stimulates granulation as it stimulates granulation of tissues. And there was no recommendation possible for topical sucralfate and derivatives, gastric protectants with angiogenic effect, hyaluronic acid and ascorbic acid. Prevention of radiation dermatitis. There was a trial by Jennings et al. In their lit review titled Novel Approaches to Radiotherapy Induced Skin
Yeah,
Reaction.
what is lit review?
Literature.
lit review क्या होता है?
Literature.
Sir, literature.
ठीक है, okay.
Keeping it clean and dry, gentle washing with water and use of mild soap, no rubbing of skin, no irritants, that is deodorants, perfume or creams, no starch-based products, risk of infection, as it may cause risk of infection, wear and use of natural fibers next to the skin and avoid extremes of temperature. So, management of radiation-induced acute dermatitis, prevention and grade 1 and grade 2 toxicities. Use betamethasone 0.1% or hydrocortisone 1% cream twice daily after RT session. So Betnovate can be used, which has betamethasone and gentamicin and miconazole combinations. Radiation dermatitis treatment, grade 3. Hydrocolloid dressing, that is amniotic membrane dressing, deodorant and silver nylon dressing is used. For radiation-induced fibrosis, pentoxifylline 800 mg daily and vitamin E 1000 international unit per day for at least 6 months is given. Steroid application used for its anti-inflammatory action. It reduces symptoms of burning, itchiness, and clinical erythema, as well as delays the progression of skin reactions. Betnovate comes with combination of
In
antibiotics.
this slide, as well as the previous slide, you're talking of Jennings. This is from a overview by Dr. Nehal Khanna. You should, cite that. So slide के bottom में कुछ आ रहा नीचे, no? Because someone has done the trouble of reviewing the entire literature and come with an overview. Okay, carry on.
So, use of Betnovate is used for anti-inflammatory action. It reduces symptoms of burning, itchiness, and clinical erythema, as well as delays progression
And
of.
who's speaking right now? I'm sorry, I forgot your name. Who's speaking?
Sneha, sir.
Sneha. Do you know Nehal Khanna? Who's Nehal Khanna?
Yes, sir.
You know, no? Okay, thank you. Okay.
Yeah, it's useful in prevention and treatment of grade 1 and 2 toxicities. Amniotic membrane dressings. There was a study at TMH. The sample size was 14. A moist desquamation treated using amniotic membrane dressings. There was no prior therapy, no secondary infections or comorbidities. All wounds healed with a median of 7 days of application of dressing, 4 to 16 days, and a median of 4 dressing changes, minimum 2 and maximum 9 changes. It can conform to the area of moist desquamation, creates an effective barrier to trauma and microbial penetration, retain physiologically moist microenvironment which promotes healing, promotes epithelialization. So these are the results of using amniotic dressing.
You should have shown some gynae examples. So in gynae, where do you get the moist desquamation?
So in the skin folds mostly.
Where is that skin fold?
In groinal region.
Okay, in the groin region. So why treatment of moist desquamation in groin fold is more difficult than moist desquamation? Same grade of moist desquamation in neck versus groin. What is the difference? You may not know that because you haven't had gynae posting. So anyone else, Simran or any one of you. So how is managing a moist desquamation in groin different from managing moist desquamation, say, in neck or any other area? I mean, these days, I think in the wards, fortunately, what has happened, and I don't blame you all, our external beam radiotherapy has become so good that we do not create these moist desquamation. So you haven't done, ask Supriya, she will tell you when as a resident how many patients used to be there for cradle care and how we used to manage both anal canal and even sometimes CS cervix or vagina or vulva. But you can
Skin
think and
used to
tell.
less. Yeah.
Hmm?
No, I'm just remembering that for all kind of toxicities, at least 11 to 12 beds used to be
Yes.
occupied. Yeah.
So that is have a great achievement. But once in a while, when you have a moist desquamation in the groin, they should know what is a challenge and how you manage with them. Uh, like in breast, very rarely we have to admit. I don't recall when we admitted last time a patient with a severe moist desquamation. In gynae, sometimes you all admit patient in a year once or twice or even less.
Even less, but there can be still one or two, especially with patients who have field cancerization and then they get a very long field
So low vaginal fields and all.
presenting together with cervix, vagina, and vulva.
Maybe so. I think then they have not seen only patients with moist desquamation. In anal canal also, we don't get moist desquamation these days. Any of the residents can tell?
No, no, no,
No, we
no.
don't get. Okay. So at least one of you please tell those who are writing on the comments, Arunima or Simran, you tell how moist desquamation in groin poses additional challenges and how do you deal with them? You all can speak.
Yes, sir. So because of the friction, it's difficult to keep that area dry, and there's a constant rubbing of your skin, and which is why it's a challenge
Okay, so one
in
is
anal canal.
friction. What else other than friction? One is friction, other is it remains moist, the sweat and all, okay,
Yes.
moist, and the dead skin keeps collecting there. It is difficult to clean, okay. So those are the cases. So these are the two challenges, okay. And removing, a groin fold is not so easy. If it is a fold is somewhere else, like in the axilla, you can raise your arms and the fold is gone, or with the position of arm. And for when there is a moist desquamation in the groin, how do you get rid of the skin fold? Okay, I think carry on. Yeah. And these showing these slides at the very old, some 20 years old slides, when our ward, half the ward was full with, moist desquamation. I think these are from that paper, na? Vinay Sharma's paper, old paper.
Yes, sir.
Yes.
So I think these are not relevant. I mean, we'll be shocked if we have a patient with such severe moist desquamation and which ends up in hypochromatic skin. Okay, we rarely ever get that. Okay, carry on.
So, genitourinary toxicities. Uh, these are acute radiation cystitis occurs either during or shortly after radiation treatment. The symptoms include dysuria and increased urinary frequency and urgency. It is usually self-limiting and seldom persists for longer than 3 months after radiation therapy.
You are going to tell what happened with your patient. I thought you described that.
So the patient, she did not have any acute toxicities, sir, during
Oh,
treatment.
did not have any acute toxicity. Did she receive homeopathy? What are you saying? It was not recorded or did not have any acute toxicity. What are the grades of toxicity? She had extended field radiotherapy, did not have any acute toxicity. Not even bowel toxicity, not even skin erythema. So what does it, when you tell me that this patient you gave 45 gray extended field SIB 55 gray with 25 fraction and 2 intracavities, 2 or 3 did not have any acute toxicity.
Sir, it is not reported on EMR, and I tried contacting the patient, but the patient could not be contacted.
So it is a fallacy of our system. Okay, so but would you understand, if someone tells you patient had no toxicity, would you believe that? Is it possible, humanly possible? You are rewriting the interaction of ionizing radiation with biological tissue then. Okay. So even if it is not written, that doesn't mean, see, many times we have to assume. So if it is not written, I would assume that this patient had mild grade 1 or maybe something, maybe grade 2 acute toxicity. It may not have been written in the EMR. It may have been somewhere else. Sometimes it's a prescription. Sometimes, patient may have been. So, and then, from that extreme, you're directly jumping all with such severe toxicity. So when was she treated? When did she finish her treatment?
2024.
2024. So recent, it is not a historical case. See, for many of these things, we rely on the residents to do the toxicity scoring. What is the whole purpose of weekly review? It is not to this thing, na? So our residents, how, they write down. Sometimes on the prescription, you will see. So I think who were the residents that time who reviewed her? Okay, yeah, they should be caught that she had zero toxicity. Okay, this is not to be complimented at the end of it. And at the time of intracavitary insertion, when she was admitted, something may have been written, So there are various things we have to. That's why we have to navigate through the files and sometimes it is just written on the file or the RT paper, and from there it is the gynae unit still uses that, no, that few pages of RT paper. The gynae unit, anyone can tell.
Yes, sir. Yes, sir.
So she's saying it was not, maybe it was recorded there and it was not.
It must be recorded. It is always recorded. We have to go.
Chalo. Okay, carry on. See, a theoretical discussion, otherwise we can just sit and discuss what acute cystitis symptoms, self-limiting. So in a patient of CS cervix, radiation cystitis, what other thing you need to know about radiation in the case of CS cervix?
So the bladder
Again,
don't
JR2, in a case of CS cervix, radiation cystitis, what are the additional things that you have to consider in terms of radiation cystitis?
We discussed this last time as well.
Is it always radiation cystitis?
So it can be proctitis also.
अरे proctitis अभी bladder में रहो बाबा, अभी rectum में नहीं जा रहे, है ना? Is it the cystitis is always due to radiation?
Yes.
Eh?
Prachi has written. Prachi has commented.
Written
You can
Prachi.
say Prachi.
So CS cervix में it is common. Okay. Urinary tract infection, they may be already pre-existing or during treatment they develop. So it's many times it's a mixture. Last time भी ये हम लोगों ने discuss किया था बाबा.
Yes.
Okay. And that may complicate the symptoms, may become more worse if they have urinary infection. Chalo.
I think on follow-up, yeah, so you're right, but many times actually infection results because of instrumentation for managing of radiation side effects.
That's very important point. We forget that instrumentation is also a cause of, infections.
RTOG toxicity grading.
Can I just add one more thing,
Yeah.
just for more nuances? So, I saw on your slide that you have written couple of symptoms. So, radiation cystitis is not only bleeding. Patients come with a symptom complex, right, of incontinence, spasms, and then frequent urination and other things. The evolving literature allocates different value to different subparts of the bladder. So, for example, trigonum may be responsible for some part, diffuser is responsible for another part, and overall EBRT dose, which involves full bladder, may be for another part. And I think as students and as radiotherapy practice is evolving from 2D to 3D, all of you need to have slightly more nuanced understanding of these endpoints, because ICRU and 2CC that we monitor for reducing late effects basically lies at a totally different place. we can discuss later. Maybe it's too much for JR1, but I thought I'll make a mention. Thank you.
Forward to RTOG toxicity grading. Hematuria, acute hemorrhagic radiation cystitis, grade 1. In grade 1, it is not applicable. In grade 2, it is not there. In grade 3, there is gross hematuria with or without clot passage. In grade 4, hematuria requiring transfusion. In grade 5 is death from uncontrolled hematuria. In late hemorrhagic radiation cystitis, grade 1, there will be minor telangiectasia. Grade 2 will be generalized telangiectasia, that is microscopic hematuria, and grade 3 is severe generalized telangiectasia. In grade 4, there will be severe hemorrhagic cystitis, and grade 5 is death from uncontrolled hematuria.
Where does, just go back. So where does, for example, if patient needs cystoscopic fulguration, which grade is allocated? Or if, for example, patient requires partial bladder or full bladder resection, then in which grade they will come?
Grade 4.
Hmm?
Grade 4.
Grade?
4.
And endoscopic fulguration? Because it's not written here. It's not part of RTOJ. And you can go back to CTCAE and check. There is a different grade allocation if you need endoscopic management versus surgical management. And there is often, a lot of confusion when all of you put toxicities on follow-up. Of course, we want to follow up CTCAE and not RTOG, but this lack of understanding can put everything grade 4. Please go back and see CTCAE.
Yes.
Yeah, thank you.
Management of radiation cystitis.
Sorry, are there any other risk factors apart from treatment and UTI which contribute to bladder symptoms? It is very well known in radiotherapy, modern radiotherapy papers also.
And the dose to the bladder would predispose to more.
Anything else? I thought doses, sorry. Apart from dose and apart from UTI that you have mentioned, are there any other factors which contribute?
Ma'am, during the treatment, if the bladder is full or whether it is empty, so
Give me some concrete things, right? Patient has come on late So what I'm asking is that there are large international databases which have worked into cystitis. Dose is one obvious thing. And hazar patients ke multivariate analysis are published. Smoking is an independent risk factor, may not be relevant for our country, but that is one of the strongest factor that is associated with late effects. And second is diabetes, because many of the bladder symptoms are also, for example, incontinence. They have a component of neuropathy. And then there is a natural aging of the patients that happens. So for incontinence and spasm, pre-existing diabetes is also a risk factor. Please go ahead. Thank you.
Diagnosis. We'll go for management of radiation cystitis. Diagnosis might
And I think today, because already 10 minutes remaining, we will just complete the toxicity and its management. Rest of the thing, because you have 75 slides I saw. So rest of the thing we will discuss next week. So at least we'll finish this toxicity. And mind you, before that, we had what rounds on radiation cystitis, radiation proctitis. Everything was discussed in detail. That was just, I think, 6 weeks ago. And you all have forgotten what was discussed. And again, like we are starting afresh. So you have to remember, and at least those who are presenting, they should have seen those videos or those presentation, what was discussed. Everything we discussed in great detail. And now we also discussed about the trials, how it reduces the toxicity, the parser trial, and the other trial, how it reduces the acute toxicity, which grade of toxicity, everything we discussed.
Yes, sir.
Carry on. And stop after you summarize the acute toxicity. Then we will discuss rest of it next time.
So we'll go for continuous bladder irrigation. Sorry,
Yeah.
exclude urinary tract infection and recurrence of malignancy. Investigations will be urine culture, cystoscopy with or without biopsy, intravenous urography or ultrasonography of the urinary tract. We'll go for conservative management, that is oral and intravenous hydration, blood transfusion if required, bladder catheterization, and intermittent and continuous bladder irrigation. Then intravesical instillation of alum and formalin. We can go ahead with cystoscopy with or without fulguration, hyperbaric oxygen therapy, and surgical intervention if required. Continuous bladder irrigation. Initial management of late radiation cystitis include resuscitation of the patient if necessary. If patient is in hemorrhagic shock, aggressive intravenous fluid replacement, blood transfusion is indicated. If the patient's hematocrit is low, a transurethral catheter should be inserted and intermittent or continuous bladder irrigation started, which is continued until the urine becomes clear. Most patients will respond to conservative management. If patient is refractory to above treatment, we can go for cystoscopy. Hyperbaric oxygen therapy involves the administration of 100% oxygen in pressurized treatment chamber. Mechanism is that HB is fully saturated and oxygen is dissolved at a very high concentrations in the blood plasma, which is then circulated to provide therapeutic benefits, such as increased angiogenesis and fibroblast activity in damaged tissues. An alternative treatment for patients with an underlying ischemic process that is unresponsive to conventional therapy. The advantage is absence of adverse effects on bladder structure or function, avoiding the need for surgery. HBOT is also very tolerated with few adverse effects. The most common being pressure related in the form of ear and sinus barotrauma. Various HBOT regimens have been used in general. 100% oxygen is administered at pressure of 1.5 to 2.5 atmosphere for 45 to 120 minutes, allowing extra time for compression and decompression. In addition, 5-minute air breaks can be introduced each half hour to reduce the risk of oxygen toxicity. Sessions are administered once daily for a predetermined length of time, usually 20 to 30 sessions. The Biomedical Research Foundation, Project HOTIS. Radiation proctitis. Acute radiation proctitis is an inflammatory process involving only the superficial mucosa, which occurs almost immediately after the initiation of therapy or up to 3 months after the onset of therapy. The symptoms include diarrhea, nausea, cramps, tenesmus, urgency, mucus discharge, and minor bleeding will develop in up to 20% of patients, necessitating an interruption in treatment. Grossly, radiation proctitis is an inflammatory process of the rectal mucosa that appears edematous, beefy red, and may have ulceration or sloughing. It is usually self-limiting with the discontinuation of radiation therapy. Time frame of chronic radiation proctitis can begin early, even during the acute phase of radiation proctitis, but symptoms may not become apparent until months to years later after the cessation of therapy. Median time is 8 to 12 months after the completion of therapy. Symptoms, those of acute radiation proctitis include severe bleeding, strictures, perforation, fistula, and bowel obstruction. The pathology is compromise of blood supply to the rectal wall, which results in full thickness ischemia and fibrotic changes. Grossly, the intestines are pale, non-compliant with telangiectasias, and may have strictures, ulceration, fistulas, or heavy bleeding. Microscopically, there is focal distortion and destruction of small arteries and arterioles with intimal fibrosis. Chronic radiation proctitis has a significantly larger effect on the quality of life of individuals afflicted by this complication when compared to patients with acute proctitis. RTOG toxicity grading of proctitis. Acute proctitis, grade 0, there are no changes. Grade 1, increased frequency, change in bowel habits or rectal discomfort, not requiring medications or analgesics. Grade 2 is diarrhea requiring parasympatholytic drugs, mucus discharge not necessitating sanitary pads, abdominal or rectal pain requiring analgesics. Grade 3 is diarrhea requiring parenteral support and severe bloody or mucus discharge necessitating sanitary pads, and there will be abdominal distension. In grade 4 acute proctitis, there will be acute or subacute obstruction, fistula or perforation, GI bleeding requiring transfusion, abdominal pain or tenesmus requiring tube decompression or diversion. In late proctitis, grade 0, there will be no changes. Grade 1 will have mild diarrhea, mild cramping, bowel movements 5 times daily, slight rectal discharge or bleeding. Moderate diarrhea or colic, bowel movement more than
I
5.
don't think you have to read everything out of that. Carry on. Next.
Management options for acute proctitis, hydration, antidiarrheal, steroid, or 5-ASA, cessation of RT will be advised. Chronic proctitis, there are invasive and non-invasive management options. For chronic proctitis, non-invasive option, we have anti-inflammatory agents, steroids, betamethasone and hydrocortisone, metronidazole combination, sucralfate, short-chain fatty acids, and HBOT. For chronic proctitis, invasive options are ablative procedures, endoscopic and argan plasma coagulation, formalin, surgery for diversion with colostomy or ileostomy.
So shall I go ahead with the chemotherapy part?
No, no. So this is a summary. No, don't have to go. I think, I am not really very happy. You all have just copy pasted some slides from some review articles without understanding, without bringing context to carcinoma cervix. If you remember, we had separate ward rounds on radiation proctitis, on radiation cystitis, and everything else. So this would have been more focused on what happened in the case of CS cervix. Okay. So this is not really good. So what happens, suppose this patient, okay, I think next few minutes we will spend discussing. So you said she had no toxicity and then you clarified that because nothing was recorded. So I am telling you, this patient would have had some toxicity. What would have happened? Extended field RT. The next day, if you ask the patient what symptoms she may have said that she experienced. I think Supriya wants to say something.
No, after you, sir, after you.
Yeah. So if you someone has received radiotherapy to pelvis and para-aortic, 1.8 gray fraction. Next day when she comes to you, you ask her, did you had any side effects or symptoms? What are the possible symptoms she may have experienced?
So fatigue is one common symptom which
Fatigue. So first day itself she comes drained back. Okay. Okay. And anyway, what other thing which may have? For which you can give a medicine also. Fatigue का कोई medicine नहीं होता है. किसी को एक्सटेंडेड फील्ड आरटी देंगे पैराऑर्टिक एंड पेल्विस. सो और क्या सिम्टम हो सकता है?
Nishika, you can speak up. You've written. She's written in the comment.
So Nishika has written nausea or vomiting. Shreya, you have written diarrhea. First day 1.8 grade. I'm not giving her 8 grade. Okay. If I give her 8 grade, that could happen with 1.8 gray on day 1. Unlikely that anyone would have diarrhea. It may be the other causes of diarrhea. Okay. So Shreya, you got it wrong, isn't it? So, but nausea many times, especially when you're treating, abdomen as well. Okay. So they may have nausea. Sometimes even when it's a very large field, you may even give prophylactic or preventive antiemetics, or you can tell them if you feel this symptom, you can take this. Okay. Yeah, I think Supriya, you please conclude. Yeah.
No, I just wanted that if you people are looking into publications, what was missed here was Jagdish Shejul's thesis. He actually did thesis on linear trajectory of radiation proctitis, in which he put
Okay.
90 or 100 patients from our institution and mapped them for 2 or 3 years that what happened in their trajectory, both symptom wise, treatment wise, and financially. And that manuscript is published. I'll be happy to share with all of you. It will give you some good understanding. Yeah.
Oh, even financially, yeah. Okay,
Yes.
so the
Yes.
impact of it, yeah, that's very
Yeah.
important.
Yeah.
Jagdish.
Yeah.
Very interesting. So I think next week what we will discuss, you please tell us for locally advanced cervical cancer.
Chemotherapy and brachytherapy part.
Chemotherapy and brachytherapy. Okay. So in your case of CS cervix, what dietary advice you give them? Skin care, she said. Dietary advice that you give to a patient. Bolo. You have done your posting, no? Gynae posting. So what advice you tell them about diet? Bolo, 1, 2, 3. I mean, we always do that now. When in the OPD before you are doing the counseling, before the starting of the patient, or when they are they come for the first review. What advice do you give them?
So high protein diet is one thing we
So we tell them, okay, you should have so protein shakes, you advise them. Or paneer khao, chicken khao. So which is the what important part of the diet? So protein in general, most Indians have less protein in their diet. So you can tell them about protein. But what else, more important things in their diet advice will you give them?
so avoiding spicy foods.
Avoiding spicy food. So how does that help? Is it for gastritis or something else?
Yes, gastritis.
Oh yes, gastritis. So is gastritis a side effect of pelvic
No,
radiation?
no, sir.
Then
Less carbohydrates.
no. First about spices. Why do you tell them to have less spices? One day you eat, if you are not very fond of spices, okay, one day you eat a lot of spices. Next day you will know what happens. You may not have gastritis, but something else may also happen.
Osmotic diarrhea could.
Okay, diarrhea and proctitis like symptoms. The burning.
Yes, sir.
Okay, so less spices in the food. What else? Oh, all of you. I mean, we just tell it in 30 seconds or 1 minute. We tell them the patients in the OPD. So Supriya, in the OPD, these residents don't talk to patients about dietary advice, or it is only consultants do, or they are referred to dietitian for this purpose.
No, sir, on the day of radiotherapy starting, they are supposed to be giving dietary advice and also during radiotherapy. And
Review.
what is
So
very
that's what
important,
I'm asking. One of you, please tell what you there may be a leaflet. Even if there's not a leaflet, now for everything we make a leaflet, but it is all in our head. What we have to tell the important points.
and too much of protein worsens diarrhea. So actually,
Yeah.
many times in second half of radiotherapy, we advise them to go easy on proteins
Yeah.
because
You're
yeah.
right. It's not easy to digest. So I think this is, I'm not very happy with today's presentation. You can't expect consultants to train you to make a presentation for all these things. This you all have to know. You're talking about acute and chronic toxicity. Acute, first you have to, at least the acute toxicity residents have to manage. Residents prevent and manage acute toxicity. Consultants think of that this may be the late toxicity. They devise strategies to reduce late toxicity. Okay, and when a late toxicity manifests, then you require a consultant level inputs how to manage this thing. But all the acute toxicity, that's your resident's domain. Anyone by the end of the posting of a gynae, you should be actually expert in in knowing which patient will get what acute toxicity, what advice you can give to reduce the severity or incidence in the toxicity, and if the toxicity manifests, how you will manage. Okay. So
Yes.
please, and this not gynae is very important, because in gynae, as you said, it may directly affect the overall treatment time and your cure rates are compromised. So this is a very, very important point. It's not a minor thing. I think we'll end this. Supriya, any one of you want to give any comments? Then we will end the meeting here.
Ankita, you have any comment? Nothing from my side.
अच्छा क्या लिखा है? रंजना ने लिखा हाइड्रेशन, स्मॉल फ्रीक्वेंट मील्स, होममेड, प्रेफर्ड, इडली, porridge, easily digestible. Good. So hydration, she had said important that they should be well hydrated. Small frequent meals, homemade. So what we say bland, okay, homemade, preferred, idli porridge. Idli porridge क्या होता है? Sorry, I don't know. इडली को वो कर देते हैं. अच्छा, idli or porridge. Easily digestible. Ranjana, thank you. I think most of that thing you have said, and they should be non-spicy. Okay, homemade. Good. Thank you. Thank you. Anyone meeting? Okay.